All right, so this week let's talk about some of the things that I had questions given to me. So pretty much I had some coaches and some other professionals ask me about these things and what to do with them when they come see you. Um, yeah, they're kind of intense cases. There's more to the story, but I'm just going to kind of give you the key points and what to look at when it comes to these individuals. Um, just so that you guys know, and I'm going to show you where I get my resources from. I'm going to show you 3 books that I love to get most of my resources from. Just to review, but remember, I have a background in clinical exercise physiology, and I've been in several hospitals where I used to work for cardiac rehab, pulmonary rehab, you name it. And I also educated a bunch of people on that topic. Also, decades of testing them. So here's the thing. Again, I'm just going to give you the general guidelines to these diseases when it comes to activity, but always have a team set in place to help you. So meaning have a care practitioner work with you, have a specialist work with you, have an exercise specialist work with you. You'll also have to look into physical therapy at some point. You'll have a huge spectrum of a team when it comes to these certain diseases, especially when you get out of a phase 2, phase 3 scenario and you kind of end up being on your own. So always have a team with you and not just one person. That's pretty much it and undergoing. So like I said, we're just going to go over the top of all these things that we're asked to be this week and pretty much what we would want to do with this. There's a few diseases out here which is they're complicated, but they don't have to be. The biggest thing with these things is people are scared of them because, well, you could die from this stuff. So what can we do to make sure that no one gets hurt? To make sure that no one gets hurt. And this is what we can do. Starting off with peripheral neuropathy, we need to look at where this is coming from. Think of it, again, it's losing sensation in the bottom of your foot. You can't feel your hands. You lose your proprioception in the peripheral ends of your body, right? That's the easiest way to explain it. And there's a lot of causations behind it. And it could be from a spinal nerve being compressed. It could be from arterial diseases. It could be arterial, cardiovascular diseases. It could be from a neurological degeneration disease. It could be from a lot of different components. So you need to look at, hey, where is this coming from and what is the attached disease to it? So a simple one that does occur a lot of times is lymphedema, right? So lymphedema, swelling, it will ruin your proprioception and it will cause peripheral neuropathy at a certain point. The other thing to take account is that everybody has a different gradients of it. So with these guys, we want to look at what is the causation behind it. So working with their care doctor, working with their specialist, asking them questions, what medications they're taking, when do they feel the most sensation, when do they not feel the most sensation. So me as a practitioner, the only thing that we could really do is try and stimulate those areas and try and get things to flow better, especially the hemodynamics, right? So checking blood pressure, checking circulation of the feet, getting them to move, mobilize that area, improving their cardiovascular health just in general. If those are the things that we want to do to try and improve these things. Other skills that you can incorporate to it. So what I usually do with people that have peripheral neuropathy is we'll do a sensory assessment where I'll draw letters in the bottom of the foot and ask them, can they feel this? I will pinpoint, hey, where is it that you have the most feeling? Do you have it in your upper foot? Do you have it in the bottom of your foot? Do you have it in your heel? And then we try and do patterning imagination. So it's almost similar to mirror therapy, where I will have them feel the point where they have the most sensation, and I want them to imagine all the movement coming through that sensation. Imagination is key, right? You could do tactile cueing, you could do taping, you could do anything that gives that sensory heightened feel. The other day, for example, I had one person give me toe extension on the good foot, and then toe extension on the opposing foot. I told him, remember how the good foot feels like when you do toe extension. Now I want you to imagine that toe extension on the right side, and do that over and over again, and continue doing that till you get tired, give yourself a break, and then repeat. The idea is that when you provoke a feeling, it's easier to understand the feeling and trying to associate it with the other limb that's not feeling so well. Aside from trying to work on everything else that's going on, um, getting the lymphatic to mobilize with activity, motion, manual manipulation, things like that, right? So the more that you could give sensations, the better. He had nothing going on with the foot aside from that, so we did some vibrational therapy. We did some vibrational stuff for the foot, trying to wake up some offering nerves, some singing nerves in the skin. Uh, did some taping, did all that, and he did pick up some sense. So with that and with time and dedication, he'll get a little bit more sensory until the root cause gets better resolved, right? So that's peripheral neuropathy. There's a lot of ways and a lot of things that could create that problem, and you have to have a team to actually help you work with that to try and mitigate some of the side effects of what could be creating the peripheral neuropathy. This one's a fun one. I haven't had this next disease, in a while. Pulmonary hypertension. So the easiest way to explain it is that you have arteries and veins right in between your heart and your lungs. Right? That's how they export blood through the lungs and to the heart, back and forth. When you have pulmonary hypertension, those guys are pretty much overloaded and they're hypertensive. It's a problem because it will create a lot of issues in the sense that fatigue is more onset, higher likelihood of other pulmonary diseases, likelihood of not being able to breathe significantly, a lot of different things, and could lead to sudden death, which is not a good thing. You don't want that. So when you have someone that has pulmonary hypertension, you just have to be extremely freaking careful not to overload them in specific ways. So avoid all Valsalva maneuver. So anything that has to do with upper body ergometry, it's kind of like don't do it, because you're giving the opportunity of creating Valsalva maneuver, which is a problem, right? If you guys don't know what Valsalva maneuver means, it just means that you're holding your breath, you're building up that pressure, and then once you let go, that pressure just shoots straight up into your upper cavity, into all this, and creates, some people get dizzy, some people pass out. It's just too much of a rush of low blood pressure to high blood pressure, right? So upper body ergometry is usually, get away from it, right? Upper body weight training, heavy, or anything that is considered heavy subjectively to that person, is kind of like don't do it. Why risk the chances of them going through Valsalva maneuver? Find a different alternative and pay attention to the breathing pattern. That is the biggest thing when it comes to these individuals. So what are some things that you can do with them? Well, you can do some cardio. You could do some light cardio. You could do some very moderate cardio, as long as you got them tested. And you had a full team. You guys did the proper testing to look at what is their functional capacity, what is their breathing tidal volume, what does it look like, and where are some things that we could improve to effectively still keep them moving. You could do respiratory training. A lot of different things, a lot of different components that you could acquire. Some cases, this disease is usually attached with another disease. Usually, because it's an offset of trying to compensate for that disease. For example, if you have chronic heart failure, this is going to try and pick up the slack for that. If you have COPD, you'll see some of pulmonary hypertension associated with it. It's not a causation, so it's a likelihood. Then you got to make sure that you're monitoring those diseases as well. Again, full freaking team. Have a full team, people that know what they're doing. Don't go ham, meaning unsupervised, high intensity activity is a no-no. Checking blood pressure, checking medications, regulating medications, keeping track of everything before, after, in between activity. How do you feel the next day? How do you feel during? These individuals need to have activity. Everything on this list need to have activity. And because, again, without activity, people adapt, they get worse. So it's a vicious cycle. So someone that's sedentary, they just get worse. So some form of activity, even if it's very light or assisted. So meaning with these individuals, sometimes you might want to have them do stimulated activities like STEM therapy with PTs, things like that. So then that muscle mass doesn't get lost, or you get them into bradykinesis, you still keep them active and they don't lose that motion. A lot of different components. Just got to be careful with that in the sense like, hey, are you paying attention to what you're doing on a regular basis and how do you feel? Sick cell disease. Pretty much this one, guys, is think of the red blood cells have a little bit of a deformity. They stick more to the artery sides, the venular sides. They're not the most proficient in carrying oxygen, things like that. So, again, symptoms would be fatigueness, tired, aches, pains, a lot of other complications they're more likely to get. Secondary cardiovascular diseases like stroke, things like that. Again, just like the other two diseases, we want to make sure that we're checking blood pressure before, after, in between activity. These individuals have a care doctor that's monitoring their medications. You're keeping track of that stuff. You're providing it to the caregiver or the medical professional that's supervising them. You're tracking all this information for them. Same thing. They shouldn't be doing any high intensity activity without supervision, or at least educated in that process of how to go on about it, right? What things to prepare, what things not to prepare. They're all similar aspects that we want to look at each one of them. Checking AVO2, checking oxygen uptake, checking all these other components. Same thing with the last one, which is sick sinus syndrome. So think of the I'm going to butcher this, the SA node having a dysfunction, right? Not really self-regulating, a lot of arrhythmias, things like that. You're going to have the same prescription for these people. So you're going to monitor their blood pressure, monitor their AVO2, you're going to monitor their breathing, you're going to, depending on how bad the condition is, they might have a pacemaker. You want to monitor how they feel. You don't want to go up a certain level of heart rate. This is why it's important to have a care provider and then a huge extensive team, because each one of them requires some form of data input. So each one of them should undergo some form of a GXT supervised by a doctor and then see where the limitation is, at least 80-70% of their max predicted effort. And even small minor tests like a 6-minute walk test could be ideal depending on the individual's functionality. But I would look at each one of these and pretty much have them do the same thing. What exercises can we avoid Valsalva maneuver? Can we do single arm activities, single leg activities? Because it's less pressure for the body, less likelihood of creating that thoracic, pelvic, lumbopelvic pressure that might go into the Valsalva maneuver. The more I could avoid that, the better. And of course, making sure that we're checking in on them on a regular basis. How do you feel when you go to sleep? How do you feel when you wake up the next day? How do you feel after activity? How do you feel before activity? What did you have to eat? What didn't you have to eat? What things are you doing at the moment? Did you take your medications today? What time did you take your medications today? What level of medications are you at now? It's important because depending on dosage and time, you'll have a different response with each activity that you do. So there's a lot to look at when it comes to clinical physiology. It's not easy. It's one of the reasons why you don't see a lot of professionals out there working in this space, because it is complicated to make sure that everybody is safe with activity. And then taking on the risk, it's not simple. But yeah, guys, at least I wanted to give you a little bit of information of what to look at, what to do. There's so much more to this, but I'm not going to bombard you with so much information that might break your head. Again, track everything every day. Have a professional at your deck. Don't do this by yourself. Yeah, I'll see you for the next one.